Well, hello everyone, and welcome back to the transition program webinar. Hello, if this is your first time attending, or again, welcome back if this is a second webinar or third that you have picked up to watch us. Today we have the pleasure of having Dr. Angela Quain speak about women's health and congenital heart disease. Dr. Quain worked in medical sleep research prior to attending medical school, as she has always had an interest in the overlap between lifestyle and health. She attended Eastern Virginia Medical School in Norfolk, Virginia, followed by a combined internal medicine and pediatrics residency at Indiana University, where she was first exposed to the challenges of care for women with congenital heart disease. This propelled her to complete fellowships in pediatric cardiology and adult congenital heart disease here at the University of Michigan, where she is now an assistant professor with the Michigan Congenital Heart Center and a member of the cardio obstetrics program. Current research projects include looking at placental dysfunction in pregnant women with Fontan physiology and using a structured exercise program to help women with congenital heart disease who are postpartum. So please welcome Dr. Quain.
Great. Thank you so much, Andrea. It's a real pleasure to talk to you all tonight, and welcome to everyone. So tonight I will hopefully be able to provide some guidance about what it means to be a woman with congenital heart disease and ways you can protect your heart and your health. During the talk, please feel free to submit any questions through the Q&A, as we would welcome an open discussion at the end of the presentation. All questions and concerns are encouraged, and I really would like to give some time for input from our extended team as well. All right, and so just to give everyone a quick overview of tonight's topics. Tonight we're going to be talking about how congenital heart disease and transition are different for adolescent and adult females. We're going to cover some important questions and conversations to have with your healthcare team. We're going to discuss some preventive care issues specific for women, including vaccines, health screenings, mental health, and exercise. We're going to talk about pregnancy in women with congenital heart disease, and then the importance of pregnancy planning and the use of contraception. And then at the end, we'll touch base a little bit on some of the resources that we have at the Congenital Heart Center for our transition patients and any women with congenital heart disease. So just a quick review of congenital heart disease. As we've mentioned in our webinars before, over 90% of children born in the developed world with congenital heart disease will now survive into adulthood. There are currently more adults than children living with congenital heart disease in the US, and half of these adults are women. And we are finding in our practice and many other centers that more and more women born with congenital heart disease are seeking reproductive and pregnancy-related care. So how is congenital heart disease different for females? Well, just note, some patients are bothered by the term disease, and as they feel this implies sickness, but this is just a descriptive term we use. We are learning more and more every day about what it means to be an adult with congenital heart disease. And in congenital heart disease, as with many other medical conditions, there are differences in how men and women experience their health. And especially as women get older, there are differences in how their body adapts to having been born with a congenital heart defect. In fact, studies have shown that women with congenital heart disease lived shorter lives and were more likely to develop heart failure, which is a feared complication of having congenital heart disease. Women are also more likely to have something called pulmonary arterial hypertension, which is a known complication of several forms of congenital heart disease that can be very difficult to manage. In addition to congenital heart disease, we've learned that there are differences in the risk of developing something called coronary artery disease, which is what we typically think of with adult onset heart disease. There are also differences in the risk of osteoporosis or weakening of the bones as we get older. We typically think of this in older women, but we are finding that women with congenital heart disease who are younger are exhibiting earlier signs of osteoporosis. We're also finding that there's an increased risk of frailty, depression, anxiety, and certain cancers. These differences seem to be multifactorial in that some of it is a difference in biology, some of it is lifestyle, and some of it is cultural. For example, men are more likely to smoke than women, and women are less likely to pursue weightlifting exercise. We have also found that women with congenital heart disease have more difficulty with psychosocial adjustment and with self-esteem when compared with men with congenital heart disease. For all of these reasons, preventive care can and should look different for women. And in addition to all of these differences comes the question of reproductive health and pregnancy and how to have a healthy pregnancy when you also have congenital heart disease. So how is transition different for female patients? In general, cardiologists are not well trained in addressing issues such as sexual health and contraception. However, discussions of family planning and the safety of pregnancy need to be happening during pediatric care. The longer this is delayed, the higher the risk of unplanned pregnancy in a high-risk patient. And discussion of topics need to be a routine part of visits in adolescents and young adults with congenital heart disease. In fact, the American Heart Association states that the primary cardiologist, not the gynecologist or the primary care provider, is the best person to discuss contraception in teenagers and women with congenital heart disease. A way to overcome some of that discomfort that can happen on both the providers and the patients is to make these discussions a routine part of their visits and therefore make it a little more normal. The transition team can help with resources and referrals to appropriate women's health providers as needed. So with that in mind, I want to take a comprehensive view of what it means to be a woman with congenital heart disease, and I want to start with some important conversations and questions. The first is, where do I want to be in 1, 5, 10, or even 20 years? This is a question for you as a patient, but it's something that you should openly discuss with your providers. By sharing your goals, you and your providers can come up with a plan for helping you meet those goals. We also have some patients who come to us saying, well, I didn't expect to live past age 5 or 15 or 20 or 40. So this is also a really good opportunity, once you set these goals, to discuss what you can expect from your heart and from your health. And I want to be clear, this isn't just medical goals. This isn't just, I want to be able to run a mile. It can include things like, I want to travel, or I want to be able to dance with my kids in my kitchen, or I want to be a volunteer firefighter. All of these questions and goals we've heard from patients in the past, and we're eager to talk about them and be a part of helping you meet those goals. So the next question is, what can I do to prevent bad things from interfering with my goals? This is about protecting your health and being proactive about defending the goals that you set, and can include vaccines, health screenings, lifestyle choices, and mental wellness. And then a third question is, what does pregnancy look like for me? Pregnancy planning is an incredibly important part of keeping your heart healthy and helping you achieve all of those life goals. Using contraception can set you up for a safer pregnancy if and when you and your heart are ready. It is also important to consider not just the heart in pregnancy planning, but other non-heart health issues that could complicate pregnancy. So as many of you know or may have already experienced, your heart health can impact so many areas of your life. As a cardiologist, my goal is to help you meet your life goals, not just to see improvements on your heart tests. So together, we recognize the importance of heart health in living your life outside of the clinic and hospital. So let's talk about some of the things you can do from a health standpoint to prevent bad things from happening and interfering with your goals. While your cardiology team is an essential part of your overall health, your primary care provider is an incredible resource for preventive care and screenings. As a cardiologist, I'm always happy to coordinate with a primary care provider to ensure that you are getting the preventive care that is tailored to your heart conditions. I like to group preventive care for people with congenital heart disease into these 4 areas, and we're going to briefly discuss each one. Vaccines are a common discussion during pediatric healthcare visits, but can sometimes be neglected during visits for teenagers and adults, especially when there's so much focus on their heart health. Vaccines have been shown to be safe and effective in people with congenital heart defects. And some congenital heart defects, such as Eisenmenger syndrome, can increase your risk of serious illness from a preventable infection. Also, some congenital heart defects are associated with impaired immunity, such as DiGeorge syndrome, which is commonly seen with truncus arteriosus, or absent spleen, which we can see with heterotaxy syndromes. These are all good reasons to make sure that you're getting the appropriate vaccines. So to the right on this slide, you'll see the CDC recommended vaccine timetable for adults over age 18. This is a lot of information, but we do recommend following this table for all of our patients. There's also a couple of additional things to consider for people with congenital heart disease. So in general, we recommend an annual COVID and flu vaccine, a Tdap or tetanus shot every 10 years and during pregnancy. We also recommend the RSV vaccine during pregnancy and over age 60. The pneumococcal, shingles, and chickenpox vaccines are very important for patients with an impaired immune system. The pneumococcal vaccine in particular is very important if you have lung problems in addition to your congenital heart disease. The meningococcal or meningitis vaccine is very important if you have an absent spleen. The HPV vaccine is now indicated for both men and women, and it's effective at preventing certain cancers. And then the hepatitis A and B vaccine are indicated for everyone, but we particularly worry about those who have had a Fontan procedure, given the risk for liver disease and that these infections attack the liver. There is no vaccine for hepatitis C, but we are going to discuss screening next. So prevention and health screenings. Prior to 1992, blood products were not able to be screened for hepatitis C. This includes blood products that were used for heart surgery, even in newborns. Therefore, we recommend that anyone who had heart surgery prior to 1992 be screened for hepatitis C, particularly those with a Fontan-type procedure, given the impact of hepatitis C on the liver. Most congenital heart diseases do not increase the risk of late-onset heart disease, also known as coronary artery disease, but we recommend routine screening for risk factors, including regular blood pressure checks, as well as cholesterol checks, diabetes tests, and of course, avoiding smoking. Osteoporosis is a weakening of the bones that is most often seen in older women. However, as I mentioned, we are seeing increasing incidence of early osteoporosis and frailty in people with congenital heart disease, especially women with congenital heart disease. Weight-bearing exercise is extremely helpful in preventing weakening of the bones. Vitamin D is also an important component in bone strength, as well as many other processes throughout the body. Here in Michigan, we are more likely to be vitamin D deficient due to the long gray winters. So that's another reason why routine screening is strongly recommended. Iron is also very important in heart health, and iron deficiency is more common in women due to monthly blood loss from their periods, especially women on blood thinners for their congenital heart disease. Congenital heart disease has been associated with obstructive sleep apnea, a condition in which the airway is weaker during sleep and can cause snoring as well as poor sleep. Routine dental care and brushing teeth twice daily has been shown to reduce heart problems, particularly those with prosthetic heart valves. And though patients with congenital heart disease are not at increased risk of sexually transmitted infections, routine screening for these is recommended as a setup for healthy pregnancies. So next up in prevention is cancer screenings. Several large population studies have shown that people born with congenital heart disease are more likely to develop cancer. Cancer is the fourth main cause of death in patients with congenital heart disease after heart failure, pneumonia, and sustained ventricular arrhythmia. For women with congenital heart disease, the most common types of cancers are breast cancer, colorectal cancer, uterine cancer, and leukemia. For people who have undergone a Fontan palliation procedure, there's also a particular risk for liver cancer. Alarmingly, adult patients with congenital heart disease are actually less likely to get their age-appropriate cancer screening, and that's especially true in those with more complex diseases. It seems that the focus on the heart often diverts our attention away from routine screening. We recommend routine screenings, which include mammogram for screening for breast cancer starting at age 40, a colonoscopy screening for colorectal cancer starting at age 45, pap smear looking for cervical cancer starting at age 21, and then for those who have had a Fontan procedure, we start liver ultrasounds and an AFP blood test. We start checking these 10 years after the Fontan operation. So next up in prevention is lifestyle. Lifestyle is a broad term that encompasses a lot of seemingly non-medical aspects of your life. However, we know that all of these things can have a dramatic impact on your health. Many of these are whole topics on their own. And in fact, exercise, mobility, and movement was already discussed by Dr. Jessie Hansen in a prior webinar. And sorry, I just want to mention with exercise is particularly important when we start looking at frailty and osteoporosis prevention in women. Mental health care was discussed by Dr. Kelly Rea in our last webinar. We know the importance of screening for depression and anxiety in men and women with congenital heart disease, as these can have a profound impact on their heart health, not just their mental health. And then travel and being prepared when away from home will be discussed by Dr. Mark Norris in our next webinar in January. So given these other webinars, I was not going to dive deeply into these topics here, but for the remainder of the webinar, this webinar, I want to dive into one particular lifestyle consideration that is essential to discuss, which is pregnancy, pregnancy planning, and contraception. I'm actually talking about pregnancy before contraception because the risks of pregnancy and congenital heart disease covers a broad spectrum, and this drives a lot of our discussion about contraception. So the question to start with becomes, what does pregnancy look like for me with my congenital heart disease? The truth is, there's no one-size-fits-all answer. So we're going to start by looking at heart changes in normal pregnancy and then how that impacts congenital heart disease. So this graph shows the rapid and drastic changes in demand on the heart throughout pregnancy, delivery, and the postpartum period. As a woman progresses through pregnancy, there's increased demand on the heart to meet the needs of both the mother and the growing baby. The left ventricle of the heart dilates in order to pump more blood with each beat, and the heart rate increases in order to increase cardiac output. There's an increase in total blood volume, and the blood pressure decreases in order to drive blood into the placenta. This all starts during the first trimester, which is towards the left here, and then rapidly increases through the second trimester. And then that high output state is sustained through the third trimester and the remainder of pregnancy. In the middle panel, you can see delivery, where we see really drastic shifts in blood pressure and fluid volume. And then after delivery, there's a return to baseline, but this is a gradual process that can take anywhere from 6 weeks to 6 months to fully recover. So when we take the impact of pregnancy on the heart and apply it to congenital heart disease, we encounter some pretty unique challenges. Some forms of congenital heart disease result in a near maximal output at baseline, and therefore they have a lot of trouble with further increasing their output to meet the demand of pregnancy. Scarring around the electrical system of the heart can make it difficult to increase heart rate, or the further demand on the heart can increase the risk of arrhythmias or abnormal heartbeats during pregnancy due to that scarring. The increased blood volume can cause worsening fluid retention. And then anemia, which is common during pregnancy, can cause worsening cyanosis in women with a single ventricle. Pregnancy in general increases your risk of clot formation, and a blood clot can be particularly harmful to the heart, especially if you have a mechanical valve, arrhythmias, or a Fontan connection. It's really important to remember that some of these changes can recover after pregnancy, but some of them do not recover fully, and some of the changes may be permanent. So with all this information, how do we break this up into counseling a patient? So we start with before, during, and after, which is if someone comes to me before they get pregnant, we talk about your individual risks with pregnancy and ways to improve your heart and set you up for success with pregnancy. This is called a preconception preparation. We then look at the heart risks through the different stages of pregnancy, which we call gravid compensation. And then this includes not only during pregnancy, but also during delivery. And beyond that, we look at the recovery and the possibility of long-term complications. After that, we look at what I call mom, baby, and in between, which is where we ask, what are the risks to the mother and what are the risks to the baby? And with mother, especially with having congenital heart disease, there's an increased risk of heart failure, arrhythmias, and thrombotic events, as we already mentioned. And then in babies of mothers with congenital heart disease, we see that they can have poor growth during pregnancy and are more likely to be born early or premature. Now, this panel in the middle is obstetric complications. So this is really things that are unique to pregnancy and delivery and include things like having high blood pressure or developing diabetes only during pregnancy, preeclampsia, which is a high blood pressure disorder that occurs during pregnancy. And then we also talk about the mode of delivery and the anesthesia plan. So the risks and benefits of having a C-section versus a vaginal delivery, and then also whether an epidural is the safest mode of pain control during delivery. So in addition to that sort of framework, we have this guide from the World Health Organization that has looked at the outcomes of pregnancy in large groups of women with congenital heart disease. And they found certain patterns in which types of congenital heart disease seem to have more problems with pregnancy. This is called the Modified World Health Organization Pregnancy Risk Classification. This creates 4 classes to help define the actual risk with pregnancy. The classes range from 1, which is the least risky with pregnancy, including mitral valve prolapse or a repaired atrial septal defect, all the way up to 4, which is considered the most risky and most likely to have significant problems with pregnancy, which includes severe symptomatic aortic stenosis, severe unrepaired coarctation of the aorta, or a weakened heart muscle with ventricular dysfunction. Most people that we see fall in the 2 to 3 range, which includes repaired tetralogy of Fallot, a systemic right ventricle, such as with congenitally corrected transposition, and also those with a Fontan procedure. These classes help determine not only how risky pregnancy is, but also how often we need to see these women during pregnancy to develop a safe delivery plan. So we are very fortunate here at University of Michigan that we have a comprehensive care model for pregnant patients with heart disease. This is part of a dedicated team for providing the care necessary for higher risk pregnancies. This team includes the primary cardiologist, a cardiologist who specializes in pregnancy, a high-risk pregnancy obstetrician, which is also known as maternal fetal medicine or MFM, an anesthesiologist, a pharmacist to help with medications during pregnancy, a dedicated social worker, and nursing support. Most patients will have at least one visit per trimester with their cardiologist, along with an echocardiogram, as well as visits with high-risk OB and an anesthesiologist. There's an increased risk of congenital heart disease in the babies of mothers with congenital heart disease. Therefore, we recommend a fetal echocardiogram during the 2nd trimester or at about 20 weeks for all mothers with congenital heart disease. And then depending on how things are progressing during pregnancy, there may be a need for more frequent visits. And some women need to be admitted to the hospital for days and sometimes even weeks or months prior to delivery. So if pregnancy is your goal, how do you get there? We have an option that kind of helps bridge this gap. This is called a preconception visit, and the goal is to get you to a safe and healthy pregnancy. This is a special visit with an adult congenital cardiologist and a high-risk obstetrician or MFM who specializes in the care of women during pregnancy with congenital heart disease. Just to be clear, this is before you get pregnant. At this visit, we review all of your heart information with the idea of asking ourselves, how well will this person tolerate pregnancy, and what can we do to set them up for success? We will discuss your current medications and see if any need to be changed because they could be harmful to the fetus. That includes ACE inhibitors and blood thinners. We can also discuss if genetic testing would be helpful, as there's an increase in risk of children having a heart defect when the mother has a heart defect. Certain tests before pregnancy can be performed to help us with that risk assessment. And that can include like an exercise stress test or a cardiac MRI. The one thing that we've learned is that we are best set up for a successful and healthy pregnancy when it is planned, as in when we have had the opportunity to address these concerns, adjust your medications, and make sure that you are on effective, safe treatment during pregnancy. So that's what leads me to my next topic, which is contraception. So I've had several patients tell me that they were told they couldn't get pregnant. And there used to be a lot of fear and unknowns about the risks of pregnancy with congenital heart disease. Women were often advised against pregnancy because of these unknown risks, but that has improved significantly over the last several years. I think the difference in the statement of you can't get pregnant is there's the physical ability to get pregnant versus the ability to have a successful and healthy pregnancy. The truth is that the vast majority of women with congenital heart disease can get pregnant, but that doesn't mean that everyone who can get pregnant can tolerate the physical demand of pregnancy. And this is where having these conversations with the transition team and your cardiologist is so important, and why we need to talk about planned pregnancy and birth control. So there are lots of contraceptive methods, and we're going to go through the most commonly used ones. When we think about the choices of different contraceptives, we really look for what's known as the ideal option. And so some of the things that we look for that are ideal are something that is easy to use and maintain, something that is reliable and effective with both, quote, typical use and perfect use, something that is safe, as in it doesn't increase risks to your heart, but also protects against sexually transmitted infections. And then something that is reversible if that's something, if you are looking at getting pregnant in the future. The World Health Organization has proposed this ABCD classification of contraceptive risk. So the ABCD stands for A, always usable; B, broadly usable, so usable in most types of congenital heart disease, however, there may be some exceptions. C, caution in use, as in there may be some complications with using this type of contraception. When we talk about these ones, we will counsel you on the risks, and it would need to be a risk-benefit discussion that you, as a patient, you accept some of the risks, and also that you are not interested in any other form of contraception. And in these cases, the benefit of contraception or pregnancy protection is outweighed by the risks of using the contraceptive. And then D is do not use, or the risks of use are excessive. So the first form of contraception that we'll talk about is abstinence or withdrawal. Abstinence is not engaging in sexual intercourse, while withdrawal is stopping intercourse prior to ejaculation. There are often cultural reasons or personal choice reasons why people use this. This does not provide any protection against STIs, and the pregnancy rate at 1 year with use is about 73%. So that also means about a 27% failure rate. So as far as your heart is concerned, this is considered an always usable form of contraception. However, we recommend a backup method due to the high risk of failure and the risk of getting pregnant. Next is the rhythm method. And the rhythm method means that you avoid having sex on days in which you are likely to be fertile. And you can see this calendar on the right side of the screen that kind of shows the days when you are most fertile and days when you are less likely to be fertile. And so it's considered safer to have sex during those days to avoid pregnancy. Now, this involves monitoring your body temperature, your cervical mucus, and your menstrual cycle. And because of the timing, it's really important that you have regular periods in order to use this method. This method does not provide any protection against STIs, and the success rate is about 75%, meaning that women who use this method, 75% had not had a pregnancy in 1 year of use. This is considered always usable in that it does not present any risks to your heart, but again, because of the high failure rate and risk of pregnancy, we'd recommend using a backup method. So a commonly used backup method is barrier protection or barrier methods. These include condoms, diaphragms, or sponges. These can be purchased over the counter and can be used in combination with other methods. You do have to be cautious if you have a latex allergy, as many of these products contain latex. And in general, these do provide at least some sexually transmitted infection protection, but it does depend a little bit on the method. Now, with typical use, the male condom is about 86% successful, where 86% were pregnancy-free at 1 year. The female diaphragm is about 75%. And Because of this failure rate, we really try to encourage perfect use, using protection all the time, every time. But these do not present any risk to the heart, and so we consider it an always usable method. So next is the hormonal methods, which these are some of the most popular methods that are used in the general population, but they have some additional considerations when talking about congenital heart disease. These include pills like orthocycline, although there are dozens on the market under many different trade names. The patch known as Ortho-Evra, and the vaginal ring known as NuvaRing. These all contain both estrogen and progestin. They're only available by prescription. They do not provide any protection against STIs. And they are reversible, though some of them may take a few months to be fully reversed, even after stopping usage. That can be very variable and unpredictable. With typical use, the success rate is about 92% pregnancy-free at 1 year. However, because of the estrogen content, we classify these as a C or D, as in extreme caution in use in patients, particularly those with a Fontan procedure, severe hypertension, mechanical valves, pulmonary hypertension, a history of smoking, or some high risk of clots. Now, I say C because for some patients, the risk of pregnancy may outweigh the risk of the increased risk of clot formation. And so in these cases, we prefer at least this form of contraception rather than no contraception. And then in these cases, we may recommend the NuvaRing just because the ring has the lowest dose of estrogen. Next, also in the hormonal methods, but slightly different, are the progestin-only methods of contraception. These include one type of pill, which is called low estrogen, the injectable known as Depo-Provera, and then the implant known as Nexplanon. These do not contain estrogen, they only contain progestin. They are time sensitive, as in if you miss the pill, like within a day or two, your fertility returns, and the pill really needs to be taken at the same time every day. Also, if you are getting the Depo-Provera injection and you're, a few days to a week late, you could be run the risk of pregnancy during that time. The Nexplanon is this little rod that gets implanted in the arm, which you can see in the bottom picture here. It does require a procedure, but that procedure does not require anesthesia. The pill you take every day, and the injection, it happens every 3 months. The Nexplanon is effective for 3 years, whereas the injection is effective just for the 3-month time period, and then the pill is effective day to day. With typical use, 92% were pregnancy-free at 1 year with the pills and injectable, and then 99.9% were pregnancy-free at 1 year with the implant. So very effective methods. Now, these are in the A to B category. We say broadly usable. They may impact INR, and so patients who are on warfarin might need closer INR monitoring if they choose this method. Next is the IUD, or intrauterine device. This is inserted into the uterus through the vagina. It's a procedure, but it is not necessary to have anesthesia for this procedure. We do recommend that this procedure be done in a monitored setting with somebody who's comfortable with your type of heart defect. The progestin in the Mirena IUD is released only to the lining of the uterus and not to the bloodstream. So it avoids a lot of any of those concerns about INR monitoring that we see with the other progestin-only contraception contraceptives. The Mirena lasts for 5 years, and then the copper IUD, also known as Paragard, lasts for 10 years. The copper-containing IUD does not have any hormones in it. This is promptly reversible, as in once the IUD is taken out, you're considered fertile or able to carry a pregnancy. There is no STI protection with these methods, but they are very effective at preventing pregnancy. So 99.9% were pregnancy-free at 1 year. And these are considered always usable in patients with congenital heart disease. All right. Next is sterilization, which is always a procedure. There are 2 types. There's female sterilization with what is called a tubal ligation, and there's also male sterilization with what's called a vasectomy. This is a more invasive procedure. It can be done postpartum for a woman who has just carried a pregnancy and is not interested in future pregnancies, or this is done as a laparoscopic procedure under anesthesia. This is generally not reversible, and this method is very effective at preventing pregnancy with 99% pregnancy-free at 1 year, but does not provide any protection against sexually transmitted infections. This is considered always usable for women with heart defects, as having these procedures does not present any increased risk to the woman's heart disease. And then lastly, I just want to mention emergency contraception, or Plan B. This is a pill that is available over the counter that contains high-dose progestin. It must be taken within 72 hours of unprotected sex, and really the sooner the better. The high-dose progestin prevents implantation, but does not abort an established pregnancy. So there's no sexually transmitted infection protection with this, as you've already had sex by the time you're taking this. But it does reduce the risk of pregnancy by 75 to 89%. And that range is related to how soon after unprotected sex you take the pill. This is considered always usable in our patients, even though there is some progestin, just because it's a one-time dose, and it doesn't appear to present any increased heart risks. So that's it for contraception. So in summary for today, I want you to think about your goals and share them with your healthcare team, including the transition team. Don't be afraid to ask about vaccines, health screenings, and cancer screenings. Pregnancy planning is an essential part of reducing your risk and meeting your healthcare goals. Contraception can help with pregnancy planning. Not all contraceptives are safe in congenital heart disease. The risk of contraceptives should be weighed against the risk of pregnancy. And then preconception visits are a helpful way to discuss your individual pregnancy risks and optimizing your heart health to have a safer pregnancy. So with that, I do briefly want to plug our cardio obstetrics program at Michigan Medicine. This is a team that also performs those preconception counseling visits. And this team is made up of the adult congenital cardiology department, which includes, going from left to right, Dr. Tim Kotz, Dr. Michael Joint, Dr. Mark Norris, and then myself, Dr. Angela Quain. It includes, we have 2 maternal fetal medicine specialists who specialize in heart disease in women. That is Dr. Elizabeth Langen on the left and Dr. Ashley Hessen on the right. We have an anesthesiologist, Dr. Megan Joseph, who is well-versed in the management of anesthesia for these patients. And then also part of the team are our wonderful ACHD nurses, Dr. Sandy Cardzella and Erica Warrington, who are familiar with some of the challenges of pregnancy in ACHD and are more than happy to help our patients. So I want to thank the transition team for inviting me to present tonight, and I really appreciate you all for coming. And with that, I'll hand it back to Andrea.
Thank you so
Thank
much
you so much.
for an amazing talk, Dr. Quain. So we do have a couple questions for you. The first question is it normal to have heavy periods with congenital heart disease?
That is a great question. So it depends. Studies have shown that young women with congenital heart disease do tend to start having periods a little later. So the average age for most girls is around 12 years of age. And for those with congenital heart disease, it tends to be closer to 13 years. And then for those with cyanosis or low oxygen levels, it actually tends to be even a little bit later, closer to 14 years. And that group in particular tends to have more irregular periods. Now, not all forms of congenital heart disease predispose to heavy periods, but some congenital heart disease do require that you take a blood thinner, especially those who have an arrhythmia or a mechanical heart valve or need clot prevention. And those patients are at particularly high risk for having heavy periods. So this can be really challenging to treat because with those patients, you need to be on the medicine. Um, and but at the same time, one of the treatments that we often use for heavy periods, like combined oral contraceptives, are generally advised against because they contain estrogen and can increase your risk of clotting. So the Mirena IUD seems to be effective at treating heavy periods and is safe in these women. And so we can discuss having that as a treatment option for those that have particularly heavy periods. If you do have heavy periods, it's important to remember that that can also increase your risk of iron deficiency, as well as like lots of fatigue. And so getting that treated and talking to your doctor about it is very important to help take care of your heart.
Great. The next question is, I've been trying to get pregnant, but have not been successful. Is this because of my congenital heart defect? Can I get IVF?
So yes, great question. There are lots of different reasons why women can have trouble getting pregnant. We know that some forms of congenital heart disease do have a higher risk of miscarriage. And actually, I wasn't sure I would have time for this, so I moved this slide, but I'm happy to show it here. Let me see if I can. I'm going to skip ahead just a little bit. We'll come back to these. Here we go. Yes. So this is an image that shows the rate and risk of miscarriage in different forms of congenital heart disease. And we see that there is a high rate, even up to like 50% in patients who are blue or cyanotic or patients who have had a Fontan procedure. And there's no denying that a high rate of miscarriage can be really physically, mentally, and emotionally demanding. So the preconception visit, not only will we talk about how safe pregnancy is for you, but we can also talk about what we can do to help for women who are struggling with fertility. So we can look at both heart reasons and not heart reasons why you may be having trouble getting pregnant. I think you also asked about IVF. That's an excellent question. There is some increased risks with congenital heart disease since IVF often requires giving high doses of estrogen. However, we review this on a case-by-case basis in coordination with your fertility treatment team to see if this is a safe option for you. Great question, though.
The next one is, should I take vitamin D or iron supplements?
Good question, especially because those are available readily over the counter. Um, I think everyone should be screened for vitamin D and iron deficiency, um, which is done really with a simple blood test. And this can really help guide whether supplements are indicated and would be beneficial. And more importantly, how much you need. I know with some of our patients, oral iron just doesn't seem to cut it, and we actually end up doing intermittent iron infusions to help keep their iron levels up. Um, I do want to mention, though, that we do strongly recommend taking prenatal vitamins if you are considering pregnancy or leading up to and during pregnancy, as pregnancy does place an increased demand on your vitamin and iron stores. I hope that answers your question.
And one more question. I'm a male with congenital heart disease. What is my risk of passing that on to my children?
Also a great question. The So there are some congenital heart defects that are more likely to be passed on, and some that are maybe a little bit less likely, but still more than the general population. So in general, we see that about 5 to 10% of children born to parents, whether that's mom or dad, who have a heart defect, are have a congenital heart defect. So about 5 to 10% is the risk of recurrence, is what we call it, when the child also has a congenital heart defect. There are some genetic conditions and where that risk goes up. And so that's something where I think it's really important to talk to your cardiologist who knows your heart in particular about that risk and see where you may fall, and if there is a higher risk. Great question, though.
Well, that is the end of our talk. Thank you again, Dr. Quain, for coming and speaking with us. Just a reminder, as we kind of talked about before, our next talk will be on travel by Dr. Norris, which will be January 14th. There we go. And then, we are looking for possible suggestions for future discussions. So if anyone has any feedback, please contact us with anything that you as patients and family members would like for us to discuss. And then also, if anyone is listening to these talks and hasn't been through the transition program or wants to find out more information about it, Dr. Quain just put the information about the program. One, speak to your primary cardiologist, or you can call the Congenital Heart Center call center and they can get you in touch with myself or Elizabeth. And we can talk to you about the program, or we do have a website as displayed there. So thank you again, Dr. Quain. Thank you everyone for watching, and we'll see you in January.